Cardiology relies on troponin to confirm a myocardial infarction. Endocrinology measures HbA1c for diabetes. Psychiatry, by contrast, operates without a definitive diagnostic blood test. There are no biological assays, scans, or blood tests that can confirm a diagnosis of schizophrenia, bipolar disorder, or major depression. Instead, psychiatric diagnosis relies on the clinician's assessment during the clinical interview and the cross-sectional snapshot provided by the mental status examination. If there are no diagnostic biomarkers, it raises a question of utility. Why do psychiatrists order intensive systemic laboratory panels? The answer is that while labs do not make the diagnosis, a primary psychiatric condition cannot be clinically established until those labs are completed. Blood is drawn for two reasons. Vector 1, etiology, rules out medical mimickers. Vector 2, pharmacological safety, establishes baselines and monitors toxicities. They divide the timeline. Vector 1 dominates admission, while Vector 2 governs long-term treatment. This division ensures that clinicians do not misattribute organic physical disease to psychological distress. Identifying which vector a specific lab belongs to provides a structured way to integrate biological data into the broader psychiatric assessment. Under the DSM-5, a primary psychiatric condition is a diagnosis of exclusion. It cannot be finalized until the physiological effects of general medical conditions are systematically ruled out. For any new-onset psychiatric presentation, this process begins with a standard screening panel. This panel typically includes a complete blood count, a metabolic panel, B12, folate, and thyroid tests like TSH and free T4. Hypothyroidism is the classic example. It produces a clinical picture of depression indistinguishable from a primary mood disorder until labs return. Discovering an abnormal TSH or B12 level shifts the entire treatment pathway, moving the patient's care from a psychiatric unit to internal medicine. Intoxication or withdrawal from illicit substances can produce psychotic or manic symptoms identical to an acute psychiatric decompensation. PCP intoxication can mimic schizophrenia, while cocaine withdrawal often presents as severe bipolar depression. Because history is often unreliable in an emergency, new admissions require a urinalysis with a drug screen and a blood alcohol level. Depending on the context, clinicians may also order heavy metal screening, HIV testing, or syphilis serology via an RPR or VDRL. These add-ons are utilized when the clinical presentation is atypical or when a patient develops psychiatric symptoms later in life. A positive drug screen or infectious marker puts the primary psychiatric diagnosis on hold until the toxic or infectious element is resolved. Once the etiology is cleared and a diagnosis is made, the focus of laboratory testing shifts to monitoring the effects of the treatment itself. This table shows the range of medications available for specific conditions. Each of these drug classes requires its own unique safety protocol to protect the patient's internal organs. Before starting tricyclic antidepressants or certain antipsychotics, clinicians must obtain a baseline ECG to monitor for QTc prolongation, which can lead to cardiac instability. Mood stabilizers like valproate or carbamazepine require a baseline pregnancy test due to the high risk of birth defects. These same medications also require baseline and routine liver function tests and blood counts to monitor for hepatotoxicity and thrombocytopenia. Without these baselines, a clinician cannot accurately determine if a future physiological change is a side effect of the medication or a new medical problem. For some high-risk medications, the lab schedule is legally mandated. Clozapine carries a risk of agranulocytosis, a dangerous drop in white blood cells that can be fatal. To manage this risk, a patient's WBC and ANC are measured weekly for 6 months, then biweekly, continuing 4 weeks post-treatment. Because lithium affects the kidneys and thyroid, it requires regular serum monitoring to avoid neurotoxicity, plus renal and TSH tracking every 6 months. In these cases, the lab results are just as essential to the treatment plan as the dosage of the medication itself. Even without a diagnostic assay, biological workups provide physiological context for psychiatric judgment. Vector 1 labs defend the diagnosis by ensuring symptoms aren't from a separate medical condition. Vector 2 labs defend the patient, identifying toxicities before causing permanent damage. This process continues for years, with antipsychotics requiring ongoing monitoring for fasting glucose and lipid spikes. These laboratory protocols provide an objective anchor for subjective nuances discovered during the mental status examination. Ultimately, following these careful procedures ensures that the clinical psychiatric evaluation remains firmly grounded in the patient's overall physiological health.